Afternoon. Good afternoon, Dr. Edwards.
Hello, nice
It's
to see you.
thank you so much on behalf of all of the patients here in Portugal and in the Lusophone world. We were really honored to have you, such a distinguished guest. Professor Edwards is a professor emeritus at University College London and is an internationally recognized rheumatology researcher. And perhaps more importantly for us, he's been a very big and important friend to the ME/CFS community for over 2 decades. In the last couple of decades, debates around ME/CFS have raised important questions, not only about the science, but also about responsibility in medicine. One of the most influential and controversial studies in this field was the PACE trial, which unfortunately shaped clinical recommendations in several countries, Portugal and Brazil, and many others included. And Professor Edwards was an early and very solid critic of this study. He's been one of the most thoughtful voices examining the scientific and methodological issues surrounding that research. And more recently, he wrote a powerful letter reflecting on the ethical challenges that arise when medicine confronts illnesses that remain poorly understood. In that letter, he raised an important concern, which is very salient for us as patients. When effective treatments are not yet available, there can be a temptation to offer interventions that sound plausible or reassuring, but have not actually been shown to change the course of the illness. So today we want to explore what responsible science and clinical care should look like in conditions such as ME, CFS, and long COVID, when there's still a lot of unknowns. So thank you again, Dr. Edwards. First, we wanted to start asking you, what originally led you to examine the evidence behind the PACE trial?
Well, I got interested in ME/CFS because I was asked in to advise on biomedical research actually relating to the drug rituximab, which was something I've been working on. But I went to a conference in Bristol and I got interested in ME/CFS in general because it seemed to me a challenging problem that deserved a bit more attention. And I listened to a lecture by Dr. Peter White, who was one of the authors of the PACE trial, and he was very critical of the patients, saying that they were being anti-science and criticizing the PACE trial. But I looked at what was being presented, and it seemed to me that this wasn't a very good study at all. And I went away and had a look at it, and I could see that this was basically a trial design that doesn't work. You can't get any useful information from. And a little bit later, I was asked to act as an expert witness for the NICE guidelines for the United Kingdom and looked at it in much more detail then and became clear in my ideas about it. The basic problem is it's a trial where everybody knows who's having the best treatment, what's supposed to be the best treatment, and then you assess the treatment by asking people whether they feel better. And people will always say they feel better if they've had the best treatment, just to be polite, apart from anything else.
Right.
It's just, as somebody, I think somebody said that they were using it as an illustration of the worst way to do a trial. It's hopeless, yes.
Why did these issues matter, not only scientifically, but also for patients and clinicians? What were the implications of the study?
Well, the study was essentially comparing two psychobehavioral treatments against a control, which was treatment as usual, which really wasn't anything very much at all, and something that they call pacing, which is quite interesting in relation to what's happening now. But that was a sort of second control in a sense, although the patients have been keen to include a pacing arm in the trial because they like the idea of pacing. But the people running the trial were wanting to compare cognitive behavioral therapy and graded exercise therapy, both of which were based on the idea that if people wanted to get better and really felt they were going to get better and did some more exercise, they would get better, and they picked themselves out of this mess that they got themselves into. And all that they really needed was a psychological boost to get doing more. And the two treatments effectively do much the same thing. And it was the trial was billed as showing that these treatments worked, but if you look carefully, you see that there's really no meaningful effect at all. But that meant that patients were being offered these treatments when they didn't work. But more importantly, they were being offered treatments which, at least for graded exercise therapy, a lot of people felt that it made them worse. And I also think that for cognitive behavioral therapy, the patient is given the impression that if they try hard enough, they'll get better. And when they find they aren't better, that's really a very unpleasant feeling to realize that you're not good enough. You haven't made yourself better. And I think a lot of patients became very depressed and miserable as a result of that. And so these are treatments which are not only useless, but they're significantly harmful. And for a period of at least 10 years, 10, 15 years, no, 10 years at least, they were considered the standard treatments, and there was no justification for that.
I hear you. When I became ill, the physicians that I first saw, that was exactly the protocol that they advised for me. These were doctors that had seen me for one particular doctor was my family doctor for 30 years. And I told her, I'm trying really hard to get better. And she said, no, you just need to exercise and you need to go to, at that point, it was sort of a mind body CBT. It was a mishmash of interventions. And so I was mild when I first became ill. And then over a period of 8 months, I became progressively worse to the point where I couldn't get out of bed.
Mm-hmm.
So I think that unfortunately that guidance still is the reflex fallback option of many clinicians even today with the critiques of the study. The study has had such a disproportionate influence on medical and clinical thinking. So what lessons should the research community take from this episode, Dr. Edwards?
The thing that struck me most was that I'd been brought up within medicine to understand that trials with this sort of design simply weren't acceptable. But it was clear that within the psychology and, shall we say, sports science, therapy-based science communities, treatments of this sort, trials of this sort were considered to be adequate. And there's a well-known Cochrane review that came from Norway, which suggests that the evidence for graded exercise therapy is quite good, and it's nonsense. All these trials are completely hopeless. And I think the lesson is that the accepted standards of methodology that we've had within internal medicine, they need to be rigorously applied throughout all fields of medicine. I think there are also problems with surgery and obstetrics. They have difficulties. I've talked to people involved in these sorts of committees and things. But the psychological medicine people particularly seem to have no understanding of what is needed to get good scientific evidence from trials.
Thank you. In this next segment of questions, I wanted to ask you about what are the ethics in poorly understood illnesses like ME and CFS? Because I think for many physicians and allied health professionals, they're faced with a quandary. The biological mechanisms of a disease remain unclear, and effective treatments that pass a high threshold of evidence have not yet been identified. So clinicians want to offer something to patients, and this creates an ethical tension between the desire to help and the responsibility to ensure that the recommendations are supported by reliable evidence. And this tension leads to divergence, even in patient associations, about how high a bar should be set in terms of rigor and evidence before you can, endorse a particular strategy. So we wanted to ask you, in your opinion, because you're very knowledgeable, why does this situation arise so often in poorly understood illnesses?
Well, because it's been going on for tens of thousands of years. One of the things I learned from my father, who was a physician, was that when he started out as a medical student, there really wasn't any medicine. We're talking about 1940. Even then, there were very few treatments that actually worked. They built up a few things like aspirin and one or two, and penicillin hadn't come along. There were one or two heart drugs and things like that. But medicine has been there for 10,000, 20,000 years and more in the form of shamanism or whatever you might call it, medicine man, medicine. And people go to see doctors, they go to see therapists. George Bernard Shaw said that the difference between the human being and animals is that we like to go and see doctors. It's something built into the human needs to have somebody to cure you. And what people simply don't seem to realize is that everything's changed, because we now have a profession of we have medical sciences which can provide treatments that do actually work. Sometimes, there are side effects and there are problems, but we have real medicine. But the desire to have treatment, whatever, goes on and on and on. And I don't know, it's very, very difficult to work against that. I mean, even now, there are all sorts of therapies people will want you to have. They're on psychotherapy, acupuncture, massage therapy, whatever it is. And basically, even physiotherapy, what people call physiotherapy, is a medicine man treatment. It's something that arose long before anybody tested it, and it probably doesn't do anything, most of it. It's a very difficult thing when people are so used to the idea that one person is there to be treated and the other person is to advise and give wisdom and treatment. And most of the time, historically, that has all been a sham, and it still is to a large extent. I think there's also something which strikes me, is that we got nearest to what we really needed to do around 1970, 1980. People understood that the new medicine really did work, and that you could work out which treatments were effective and which weren't. And medicine became very scientific, and the United States textbooks became extremely rigorous and scientific. But a lot of that has gone with the internet and with commercialization. Everything is now all much more muddled up. And particularly in the United States, the rigor of medicine has gone. It's extraordinary. And so people have to keep an eye out, because you're out there in the Wild West, I'm afraid. It is very, very difficult for patients to know what they should be doing.
What responsibility do clinicians then have when the evidence base is still limited? Or even, let's talk about the medical schools too, that are preparing the physicians going forward.
Well, I think they have a responsibility to be rigorous and to teach the trainees to be rigorous, as we did in the 1980s. We used to have journal clubs, and we tore the studies to pieces, and we made sure, and the person who came out top at tea time was the one who had the sharpest question and the deepest criticism of what was there. The whole thing was taking things to pieces and showing what really was valid and what was didn't stand up. which is really what we try and do in the forum, Science for ME forum, which I'm bowled over as to how sophisticated the patient community is in terms of their understanding and their multiple skills. I'm just an old chap who gives out his ideas, but there are people in the ME community who can really move things forward and critique the science and pick out what's good and what's new.
That's very true, and certainly that's also, I think, the case in Portugal. We have many people that have been living with disease now for quite a long time. They have become experts in many ways, and we came together as an association out of a collective was precisely to try and elevate the voices of those patient experts, and to make sure that they also have an ability to have dialogues with clinicians, and that's how our Zoom talk show series came out, and to begin to also express some of these underlying concerns with some of the bad science, with some of the pseudoscience, with some of the privatization of dubious approaches. Some of you've mentioned them all, and really to protect patients. One of the things
Yes.
one of the things that we found really, really difficult is that, well, first is that treatments that are being offered are generally supported by narratives or subjective improvements or anecdotes than rigorous scientific evidence, or patients report an improvement or feeling, a little bit better. So that's hard for us because patients also need a certain degree of autonomy to try whatever they can try to find to get better, and there's an element of desperation there. So I'm not sure this is so much a question, but a framework. How should we think about the role, for instance, of the placebo effect, or in conditions where we still don't know what the underlying biology is still being investigated. Do you understand my?
Yes, there are a whole range of different questions mixed in there. I mean, and you're right. And when it comes to the placebo effect, when it comes to trials, I think most of what we see, which is bias and which is in the poor quality trials, isn't really a placebo effect. It's just the patients saying they're better because they think they better tell the therapist they're better, otherwise they'll be upset, or they might not get another appointment for the clinic or something like that. So, I mean, it's very complicated. What people call the placebo effect, people getting better on trials, there are lots of different things involved in that. But I think you're focusing more on the issue about people feel that treatments work and they want to recommend them to other people, and that's fair enough. But the way I look at this is that I think one has to have complete respect for patients' experience in terms of their symptoms, how they tell you what they feel, what the day is like, or just how awful it is. And I've listened to that over a period of 10 years, and I get a clear impression of just the range of problems that people have. But when people try and attribute one thing as a cause of another thing, and that's particularly if a treatment made them better. We know that people are unreliable about this, and it may be because they're desperate to think that something is helping. But people are very unreliable, and the reason why we have proper trials is because people are unreliable about that sort of thing. And I say to people that, you may think that this particular tablet makes you better, and you may well be right. For all I know, you may absolutely know that it makes you better, but I can't know that, and other people and the science community can't know that until we've tested it blind and in a controlled study. because we know that a lot of people are unreliable when they attribute improvement to this or that. Same applies for worsening, or, what made you worse? We don't really know necessarily. But it's difficult. And I don't think patients should feel insulted because we don't believe they say, I got better on this treatment. Or what I would say is, you may well be right. You may well have very clear evidence of your own that you've got better on that treatment. But if we want to recommend the treatment to others, we need to test it in a way that excludes the possibility that anybody is misinterpreting what's really going on. It's difficult, but it can be done. The sad thing is that it isn't that difficult to do these trials. People say, oh, you can't do trials, there's no money. Yes, you can do trials. If you're really committed to doing a trial of a treatment and it works, it's not that difficult to show it works. I've been in that situation myself with the drugs for rheumatoid, and it's tough, but if you're committed to doing it, it's doable.
Thank you. I think in the case of ME, because of the fluctuating nature of this illness and the fact that people go into temporary remission at times, it becomes even harder. And I think it underscores why these clinical trials and studies that follow patients over time are so important, because the underlying nature of this illness, with the fluctuations, the manifestations that sometimes come and go over years, in some cases in decades, makes it.
Yeah, I think that's right. And I think the patient community on our forum, I think there's a general consensus that if you're on a treatment and you're hoping to get better and you're doing your best to get better, there's often a period when you can appear to improve.
Mm-hmm.
And then 2 months later, 3 months later, it all just evaporates and you're back to where you were. I think we saw that with the rituximab studies in Norway. There were people who really thought they were better and then crashed back to where they were.
Yes. So for us, how can patients best protect themselves in terms of the wide range of programs, therapies, and theories about their illness, some that are presented with great confidence and even by multi-level marketing schemes, but supported by very little solid evidence?
Well, this is an easy question because I can do my own marketing here, you see. I think I'm not being serious, but
I know.
I think people should come and see what we discuss on Science for ME. It's not my forum, but it's a forum I greatly enjoy. I go on it every day, and people come and they begin to realize just how fragile the knowledge that we think we have is. But in the same time, they begin to realize that there are ways of finding out things, and that there are standards you can stick to, and that there is hope for moving forward in the future. I mean, people should be cautious and skeptical, because doctors will sell stuff, physiotherapists will sell you stuff without any very good reason, and that's always been the case. So be skeptical, but apart from being skeptical, I think people should educate themselves and find out. And some of the stuff is very technical. Some of the stuff to know, some of the stuff about genes and DNA, I can't make head or tail of it either. But we've got people on the forum, young PhDs who do understand. We've got people who have no biological training, but they're clever and they read the stuff and they work out and they make very useful contributions. A group of people who are committed to understanding something as important as their own illness can go a long way. And I hope that people who come to the forum they feel much more confident that they know how to judge what is being offered to them.
No, absolutely. Science for me is a precious resource in our community. In Portugal and in Brazil, what we've tried to do is mimic that on a much smaller and less sophisticated scale. But we have Facebook groups where we just disseminate the best available information and have patients
Mm,
comment on it, and essentially try and filter out approaches that we think are meritorious or even experimental approaches that in some ways address the underlying biology of the illness and that are supported by some of the biomedical processes that we know are intrinsic to our illness versus those that are not, and also caution people about things that they should not try because simply the evidence isn't there, and most of these things are offered in the private sector, and economic uncertainty and in some cases poverty is a direct result of this illness. So when people get sick, they need to be very careful how they spend the limited resources that they have, because this is not an illness generally that enables you to go back to work full time. And so it presents a lot of problems that way as well. And through our Brazilian Aliança Millions Missing Brazil, they have a listserv where they share scientific publications and comment on those as well, all in Portuguese, so that those people that have difficulty or are not able to read in English can also follow that. So I thank you very much for your engagement in Science for ME. That really is the gold standard for patient and scientific exchanges. And I think, yes, you're right. Citizen scientists and patient scientists are very important in this field. Are there particular red flags, methodological scientific warning signs that people should look out for if a particular treatment is peddled?
right. That's a difficult question. I'm not sure I've got a special answer to that question, but I would say be very skeptical if the person offering the treatment claims to know why it works,
Mhm.
because we don't know anything. That's the one thing we do know, is that we really don't know enough to be able to say why anything works. I mean, there's this treatment that the Norwegians, Øystein Flug and Oliver Meller, who I know well, and great scientists, they've been trying out a drug called daratumumab, and I'm not sure whether it works or not. Maybe it does, maybe it doesn't. But we were discussing on the forum, and we decided, well, maybe it works a completely different way from what they think. It
Mhm.
just happens to work.
Right.
I'm quite sure that Oyster Flu would agree. He doesn't know how it works, but he has an idea of why he chose it, but he'd be quite happy to believe that it works a different way too. So somebody who gives you a treatment and says, oh, we know this works this, or this therapy works this way because it makes you do this, and no.
Yeah, I think a bit of humility is always good. Um,
Yeah.
I think also thank you for the statements that you've made too about the importance of patients not feeling that they failed if a program or technique doesn't help them. 'Cause
Yes.
the other part, that perhaps the most dangerous aspect of these illnesses, of these treatments, is that the sense of failure that the patients have when these therapies don't work. And it's sometimes, most of them have a psychological element to them, that you're essentially not trying hard enough, that
Yes.
you didn't believe enough, that you didn't follow the protocol enough. So I think that's a message too for everyone who's listening to this. If you've done any of these things, and if it's failed, it's not because of you. One of the challenges in Portugal and elsewhere is that many interventions are being promoted in spaces that are very loosely regulated and sometimes are outside conventional medical oversight. So for us, I think there is a risk that vulnerable patients can be exposed to commercial claims that are not adequately supported by the scientific evidence. And what responsibility do professional bodies, scientific societies, and regulatory institutions have in protecting patients of these situations? I say this because Portugal, unfortunately, doesn't have the equivalent of the NICE guidelines. And even then, the NICE guidelines show us the importance of the guidelines being sufficiently explicit so that things don't come in through the back door, like you outlined in your letter to back me. But yeah, what responsibilities do these professional bodies, scientific societies, and regulatory institutions have to protect patients?
I think they should have much more responsibility, and they should be held to account much more. And I don't know. Again, I feel that we got close to getting the right sort of requirements maybe 20, 30 years ago. And things have, if anything, things have become more confused, less well organized. I mean, one extraordinary thing is that when the NICE organization was set up in the UK, which was, I mean, NICE has its problems, but it was a good idea that you can only have government-funded treatment if somebody's shown definitely that it's worth having and it's safe and it works. And otherwise, we're not going to pay for you to have it. Now, that should apply to the private sector too, but who regulates that? I don't know. Nobody wants to deal with a political problem like that. But when we had NICE developed and things, it was decided that homeopathy would not be allowed in government funded in the UK. And so the Royal National Homeopathic Hospital had to change its name to a Hospital for Integrated Medicine. But 10 years later, the hospital's gone back saying, oh, we're going to do homeopathy because we like homeopathy. And nobody seems to mind. Nobody seems to mind anymore. Everybody seems to be allowing all this sort of stuff to happen. And I'm not quite sure what the pressures are. I mean, it's possible that now that everybody is pretty healthy, the people don't, the issues of safety and efficacy of medical care don't come quite so much into focus. When I was a medical student, I looked after a ward of people dying in their 50s and 60s from chronic respiratory disease, cardiac, rheumatic heart disease, having strokes in their 50s, people with diabetes that couldn't be controlled. And most people weren't as tall as they should be. I mean, illness was everywhere. And I have to say, in comparison, most people now are pretty healthy. You know, they've grown to the size they should be, and they expect to live to 80 years old without any major problems. If they have cancer, that can probably be dealt with. But and so perhaps it isn't in quite such sharp focus. People think, oh, it must be all right, you know, it doesn't matter, a bit of this or that. But I don't know. To me, the politics of it have all gone wrong, and we should have much more accountability for these organizations. We used to think that we were better in the UK than the rest of Europe. We thought Europe was a bit lax. I actually think that some European countries are now better than us when it comes to regulation. And certainly healthcare systems in a lot of European countries are better than ours now. I have a long-standing Spanish friend, and when we were children, Spanish healthcare was terrible. British was wonderful. Now, you know, 10 years ago, we stood together and said, well, it's the other way around. If you know, good quality Spanish government healthcare is really excellent, and the UK is falling behind. And I don't know, I guess Portugal and Spain are fairly similar in that sort of respect. And I was very impressed by the Portuguese physicians who've come to work with me have a commitment which is second to none. But it's difficult. I don't know what. Somehow the political will has to change.
Mhm. Well, I think,
Patients just have to be careful.
right, and then the patient associations, I think, have to also play a role in trying
Yes.
to defend them. The NICE guidelines, though, for us in Portugal are very important, and precisely because they have taken a stand in terms of deciding what treatments have sufficient evidence behind them and that should be administered or funded by the state versus those that don't yet meet that threshold. So, in a context of limited resources and also limited energy of the patients, because we don't have the energy envelope to keep trying things that don't work. I mean, going to the doctor sometimes will wipe us out for a week, a month. So for us, the NICE guidelines are a very important reference. And it's something that when patients go to see their doctors, even if they do not know very much about ME, CFS, which unfortunately is still the case, the fact that the NICE guidelines exist, that becomes a reference of sorts. And we're fighting very hard to try and encourage the Portuguese health authorities to undertake a similar process for Portugal because we don't have them yet. And so we aspire to have some national guidelines in place, a set of diagnostic tools, a standard set of treatments, and training to be able to build upon what I think you really correctly stated, is the excellence of many of the Portuguese professionals and the medical education that's provided here, but to bridge that gap for ME, CFS, and long COVID. So for us in Portugal, we were a relatively small community. The estimates of people with ME pre-COVID are about 93,000. Those are using conservative estimates, 93,000 pre-COVID. Then the emergence of long COVID has really, unfortunately, increased our numbers considerably. We don't have data in Portugal that can really accurately estimate, but we think that there's probably another 150,000 to 200,000 people that are coming down with ME or very complicated long COVID conditions. So it's a sizable group. And so there's some traction now. There's some interest because this has affected so many people. And long COVID also became an occupational hazard with many health professionals who were on the front lines delivering care and became sick multiple times. And we have a number of physicians, nurses that are now patients and 3, 4, 5 years into this have now been diagnosed with ME. So, and I think that's a tragedy that another viral epidemic hit and increased our numbers, but it's also created some opportunities for visibility in this area. And I think researchers and clinicians are starting to think in a more sophisticated manner about post-viral illnesses in general. And ours was a sort of an esoteric little illness until long COVID hit. So I just wanted to hear your thoughts about that. Do you feel that we're beginning to see greater recognition of the biological complexity involved? Do you see that there's more interest? Are there new researchers entering the field, new clinicians? What has been your experience in terms of what?
It's very difficult. It's difficult to be sure, but my impression is that there are more people taking interest and more researchers coming in. Neurologists in the hospital at Queen Square, which is the main neurology centre in London, there are people there who are taking interest. And they've taken an interest because of long COVID, I think, as much as anything. people in the pain field, genetics fields are taking an interest. And there are a number of people in Australia and New Zealand who are interested, and certainly on continental Europe, Iberian Peninsula, and Holland in particular, and then of course the Scandinavians. I think things have built up, and there's a community of people who are interested in high quality methodology and doing things properly. People are still struggling to get positive results, but I think the genetics is beginning to, that's really made a big difference. I mean, I think it's difficult for the community, the patient community, to understand the impact of the Decode ME project, but I think there is a very big impact because it has shown there are 8 gene regions which are significantly linked to ME/CFS, and 1 or 2 of them we have some idea why they might be and what the genes involved are. One of them overlaps with chronic pain conditions, which makes sense because a lot of patients with ME/CFS have chronic pain. So I think things are developing, and I also think that within the wider community, you know, there are several articles in the daily papers about ME/CFS, and whereas 5 years ago they nearly always got it completely wrong, now quite often they get it right, or nearly right. Not too bad. And I think I think long COVID has raised a whole lot of rather poor quality science too, and you know, everything. As always, there are always people who rush in and do stuff and don't do it very well and don't really understand. But there are 1 or 2 crucial studies that I've seen which I think may tell us something very important. Now, just as one example, everybody knows that more women than men get ME/CFS, and the question is why? And it's because women have 2 X chromosomes and men have 1 and a Y. But what's the mechanism? And it became clear in our discussion, our forum discussions, that there are really 2 or 3 important different mechanisms. One of which is that if you're a woman and you've got 2 X chromosomes, although you're supposed to put 1 of them in the cupboard and turn it off and only have 1 like a man, in fact, there are some genes on the X chromosome where it shows up on both of them. So you have a double dose, or nearly a double dose. And some of those genes are very interesting because they're involved in immune responses and things like that. And alongside ME and long COVID, research into lupus is beginning to pick out exactly what's going on there. I mean, it's still not entirely clear, but there's a gene on the X chromosome called TLR7. And we know that's crucial in lupus. And we know that it's not entirely put to sleep on the 2nd X chromosome. It still works a bit more. And so the story looks as if it, and we don't know yet, but it looks as if the story might come together. And if we can see exactly why it is that women are more likely to have ME/CFS, and it may be just simply 1 of these genes on the X chromosome not being switched off, then we begin to see how the mechanism could work. And there are strong indications that there's something to do with the immune response, and there's something to do with the nervous system, central nervous system, maybe spinal cord, dorsal root ganglia, brain, hypothalamus, don't know what, but somewhere along those lines. And now with the internet, with Google AI, it takes 2 minutes to find out anything you want to know about these things. And there are plausible links between these various things. The question is, which is the link that's really the one that's important for ME/CFS? But there was, I don't like research on animals, but there was one study on mice where they gave them COVID and they had a sort of long COVID. And I thought, well, I don't know, not sure that mice can really have long COVID. And they were studying the impact of the X chromosomes, and it made some sort of sense. They got some sort of answer out of it. So I think there's science that can be done there, and somebody may just come up very soon with some crucial piece of evidence which shows why it is that more women have long COVID than men. And it's probably the same reason as ME/CFS, the ones that go on longer. I think actually in the short term, it's about the same men and women, isn't it? But
But I
it's
think women are
different.
coming down with the greater severity. The severity.
Yes, I think it's complicated. But when you start looking at the longer term ME/CFS type situation, then I think you have the female predominance. Interesting. I think the same applies to glandular fever and Epstein-Barr virus. In the short term, post-viral fatigue isn't particularly different men and women, but it's the long term which is the problem. I may have got that wrong, but I think that's the story. And people have data on that sort of thing for us to look at.
No, we had the Decode ME study was presented at our conference, and that was a. I mean, we had actually also Rob Wost talk about
Yeah.
his work, Risa Pretorius, Dr. Sistrom. I mean, there's I think for the first time 5 years ago, the picture wasn't as rosy in terms of envisaging that a breakthrough might happen soon or several breakthroughs. I think there's a sense that science is advancing, that we have more, but we certainly saw it in the second conference. There was a whole group of young, dynamic researchers entering the field now and starting to take this on. And there's also enough money now, still very limited, but for them to be able to sustain their research in
Mm,
this area, and
mm.
wonderful mentors, the clinicians, the researchers that stuck by us, and you're one of them, when the funding wasn't there, when there was a lot of skepticism, and where I think sometimes, um, you know, if an illness is poorly understood and the patients are stigmatized, the researchers and clinicians that defend them sometimes they get they get I don't know how to say it, but it's not an easy not an easy role for them either, because they stuck by us at a time when there was a lot of still of discredit. I'm not sure if I'm conveying what I want to say, but I hope you understand.
Yes, no, I do. I mean, I have great respect for people like Chris Ponting who have committed a decade of his career to ME/CFS. I mean, I committed my career to rheumatoid arthritis. There's no way I could have committed it to ME/CFS. It was just too uncertain. There was too little known. I would never have got anywhere. But in retirement, I can get involved in an armchair fashion, just talking to people. Maybe now, if I was a young researcher, I'd get into ME/CFS, but you have to have a lot of courage, and you have to be able to tackle a problem which is where the answer is a long way away. It may not be a long way in time, but in terms of thinking and data, it's still a long distance to travel.
No, it's
Uh,
hard. It's a thorny problem, and it's a complex problem.
I mean, I think one might argue that rheumatoid arthritis was almost as difficult in 1975 as ME/CFS is now, but we had some very obvious clues for rheumatoid arthritis, but how you put them together was very unclear. Um, but I think it was easier. Uh, but I think with long COVID and with the data coming through, and ME/CFS is something that I think seriously good people are likely to be taking an interest in. I mean, I've talked recently to scientists who think it's worth getting involved in.
Yes. So the last set of questions was based on your experience in advising the NICE guidelines. So thinking of us in Portugal, what are the most important principles that should guide the development of clinical guidelines?
You have to make an honest assessment as to whether or not the treatments, if we're talking about treatments, whether the evidence that they work is really there. And NICE is pretty good in that they have a systematic system. They have technicians who go through the papers and score them, and they come out with roughly the right answer. But they use systematic analysis, and I think so that means that the thing isn't biased by the people who are doing it. But I actually think you should have to go further than that. And one of the things I was critical about NICE is that at the end of the day, whether or not the evidence is good enough is actually a matter of fact, and you just have to think hard enough to work out whether it's good enough or not, on the basis of common sense. In that these systematic systems like grade, which is used for grading papers, they approximate to what you want, but no recipe like that is a substitute for actually interrogating and arguing through. And the simple thing with most of the psychobehavioral studies is if you have a study which is open label, unblinded, and has subjective outcomes, the result is uninterpretable. So you score 0. It's not that you score it down on grade by 1 or 2 levels. The score is 0. Start again. And I think NICE their job could be made much easier by simply looking at those studies and saying, no, this isn't beginning to be any use to us. I think the major problem in the end, they got the right answer. And the chairman was very good. I thought he understood that at the end of the day, you have to apply careful reasoning. And I think they did that. They took the grade and they didn't take it as gospel. They looked at it carefully and they came to the conclusion that, yes, this was giving us the right answer. These trials don't show us a useful result. The problem with the NICE guideline was once they decided that there were no treatments with formal evidence, they felt that they had to recommend some sort of framework of treatment. And then they started talking about activity management and all sorts of things and multidisciplinary teams and things like that, which was all very well. But I think we said earlier, it opened the door to the possibility of people saying, oh, well, there's nothing on the list officially, but we're going to give you this because, this is multidisciplinary, it's activity management, it'll do. And it looks pretty much like the old graded exercise therapy. And it's difficult. I think they should have been a little bit more rigorous at the end, but I think politically it must have been extremely difficult on that committee to come out with a guideline which just said there is no treatment. I mean, it would take a lot of courage to do that, I think. I wasn't invited onto the committee itself, but that allowed me to say certain things which I couldn't have said if I was on the committee. So yes, but I think we still have problems with what's being provided, and we're going through the process of having a government, the government's looking at producing a new template for service provision in the UK, and I'm not sure whether it's really going to turn out as it should do. But at the end of the day, the most important message for the patients is don't get involved in things that might do you harm. At the moment, there's nothing that we know that's going to cure you. So maybe just sit tight. But I think in the not too distant future, there's a reasonable chance that there will be ways of making people significantly better. And if people look after themselves and pace themselves and don't get exposed to things that make them worse, a good proportion of people may see through, and I mean, a significant proportion of people stabilize and improve, even if they go on having the illness long term.
One of the things that we tried to do through the conferences that we had in Portugal is to bring the few off-label treatments that have serious clinicians behind them, that have some type of study, the use of mestinon, low-dose naltrexone. There's now a couple other drugs that are being tested, and have the opportunity also to expose Portuguese clinicians, researchers, patients, and caretakers that there are these treatments that are on the horizon, that there are trials being undertaken on many of those, that there's some hope, that these treatments, of course, have to be adapted to particular patient subsets and according to whatever symptoms that you have. But we are now beginning to at least have some tools in the box that can help ameliorate some of the symptoms, and some of the comorbidities that we have as patients. And those should be, for us to try and disseminate those as broadly as possible, and to distinguish those from other areas where they're just treatments that are anecdotal. So sifting between the various levels of evidence for specific approaches, offering hope, but not leading people down the proverbial garden path. I think that's what.
Yeah,
Yeah.
yeah, and I think people have. It hasn't been very organized, but quite a lot of the treatments that really they do deserve being given proper trials. A number of those have now they are under trial. So naltrexone, I think there are 3 trials. Mestinon's being tried. People have tried antihistamines, and people have tried some anticoagulants for long COVID, certainly. I don't know whether any of these are really going to turn out to be useful, but the trials are being done, and there was a time when really there weren't any trials at all. But I think they are beginning to come through.
Are there any common pitfalls that governments or medical societies should try to avoid as we try to move toward the development of clinical guidelines in Portugal?
Oh, I don't know.
Did,
um, I think guidelines need to be honest.
and deliberate, right? There's a lot of
Yeah,
deliberation.
yes. We've been on the forum. We've been trying to produce some fact sheets, and I've been working on one for very severe and severe patients just at the moment. And there is really very little in the way of specific treatments that can be, offered to help people. But managing the factors that potentially upset people, like environmental stimuli, exertion, etc., etc. Getting a way of expressing the problem there and getting physicians and healthcare workers to understand the problem and the reason why it needs to be taken seriously. Is that, I think, it's quite difficult, but we're having a go at that.
I'd love to translate them in Portuguese once you're done.
Yeah, well, we can do that. I can get Maria to do that. No, I'm not sure, but I'm sure somebody can do that.
Oh, we have folks that can do it.
Yes.
You authorize
Well,
us.
but yes, and in many ways, I've always I've never really believed in being too systematic and formal about things. If everything has to be in a rigid guideline format, you end up with a whole lot of sections, none of which says anything at all. If you throw away all that and say, well, what do we really want to say to people?
Mm.
Just one paragraph of a message. What is it they have to know? As I say, with this thing I've been working on at the moment, the members immediately picked out the paragraph that had the message. It wasn't facts, it was just the message that you have to avoid these stimuli that upset people with very severe disease because it puts them back for such a long period of time. Yeah.
Lovely. So one last question for many people with ME and long COVID. One of the most difficult aspects of the illness hasn't only been the symptoms themselves, but also the long period which their experiences were questioned or misunderstood. And in the case of people with ME, we have some patients in Portugal that went 30 years without being diagnosed. So, what do you think the scientific and medical community needs to do to rebuild trust with patients?
Well, I have a particular view on this, which doesn't necessarily go down very well with a lot of people, but
Right.
I think the concept of ME or myalgic encephalomyelitis was very confused, and it put together a whole lot of things which didn't really belong together at all. And the international consensus criteria produced a complete fairy tale of a disease that didn't exist.
Mhm.
There is a disease, and I wouldn't call it ME, I would call it ME-CFS, because ME-CFS recognizes that a community of people have sat down together and realized exactly what this disease really is about. It's about chronic disability, about certain sorts of symptoms. We have no idea what is causing it, but it's there. And 0.8% of the population have it. We know that. There's no doubt about it. And I think we should move to a situation where everybody understands that ME/CFS and long COVID are real problems, real disabling illnesses, and we should move away from the rather speculative, slightly pseudoscientific sort of stuff, which arose out of ideas about ME from the 1980s and things, which are often off target. There isn't any brain inflammation there. I don't think that there's a mitochondrial problem or anything like that. I think it's actually something else. Um, but the people with the illness are there, and I think the scientific and medical community will begin to appreciate that when things like the Decode ME data come through and people see that there's a genetic basis, partial genetic basis. We might even understand what the X chromosomes are doing and things like that. And then you begin to see how to piece it together in the way that we did for lupus and rheumatoid and things. So yes, I think there's a chance that this will emerge. There's still an awful lot of this psychobehavioral cloud in the way, mist, fog, whatever it is. And most physicians in the UK still think it's a psychobehavioral problem. It's hopeless, but there is a small body of people who understand that this is it's a real scientific problem, real medical problem, and we're beginning to understand the perimeter of it, what really is, how to define it. Yeah.
Thank you so much, Professor Dr. Jonathan Edwards, for sharing your experience and
Not
your
at
insights
all.
with us. We're really honored. We hope one day you'll come to Portugal and speak to us live. We just have to figure out how and when.